In 1955, the future of modern medicine wasn't actually being developed in some pristine, sterile laboratory. It was, believe it or not, being built in a basement.
Right.
And it was constructed out of 7 beer cans, a fruit juice tin, and window screening that was holding together these lengths of cellophane sausage casing.
Which is just wild to think about today.
It really is. That incredibly scrappy, like do-it-yourself contraption was actually an early functional model of the hemodialysis machine. And, it highlights a really fundamental challenge for us. Filtering human blood mechanically is, well, it's only half the battle.
Exactly, because to actually save a patient, you have to reliably pull massive volumes of blood out of the human body
Right.
and then pump it back in over and over again without causing a complete catastrophic system failure.
And that challenge right there forms the entire foundation of what we're looking at today. Welcome to the Deep Dive. Today we are analyzing a really definitive clinical text on this subject. It's called Vascular Access, Principles and Practice, the 5th edition.
Yeah, and our mission as medical experts and, educational content creators today is to unpack the pathophysiology, the hemodynamic physics, and the severe clinical complications of, well, fundamentally altering the human circulatory system.
Right.
We want to synthesize this massive, multi-contributor textbook into a highly digestible format specifically tailored for you. Whether you're a medical student, a young professional, or just a self-taught learner who really wants to understand the core mechanisms of vascular surgery.
Because we're going way beyond just, memorizing what procedures are performed. We really want to thoroughly explain the biological and mechanical reasons why they work and why they fail.
Right, the actual why behind the surgery.
Exactly. So we'll be looking at everything from those rudimentary early inventions to the complex cellular biology of how our native vessels react to synthetic grafts, all the way to the absolute anatomical extremes, like placing an emergency central line in a premature infant.
It's a huge spectrum.
It is. So let's start with those historical origins, because to understand the surgical techniques used today, you kind of have to look at the sheer mechanics of early fluid dynamics.
Yeah.
Long before Dr. Willem Kolff was tinkering with beer cans and cellophane in the 50s, the concept of vascular access was viewed almost entirely as an architectural problem.
That's a good way to put it.
Yeah, like in the 1600s, Sir Christopher Wren, the actual architect who designed St. Paul's Cathedral, he invented an early intravenous cannula using an animal bladder attached to a quill.
Which, Wren's quill just perfectly illustrates the mechanical mindset of early physicians, right? They viewed the circulatory system simply as plumbing. Just pipes.
Just pipes, exactly.
And shortly after Wren, you have figures like the physicist Robert Boyle using early access methods to experiment with intravenous infusions. But the leap into modern access, specifically the high-flow access you need for hemodialysis, that was driven by absolute clinical necessity.
Right, because patients were dying.
Exactly. So Kolff's basement machine utilized that cellophane as a semi-permeable membrane. The blood flowed inside the casing, the dialysate fluid sat outside it, and the beer cans, they basically provided the structural rotation to mix the fluids and facilitate diffusion.
It's brilliant.
It was. It proved dialysis was possible. But here's the catch. Connecting that machine to a human vein repeatedly, it destroyed the patient's native vessels within weeks.
The veins just couldn't handle it.
Yeah.
Which brings us to the real physiological breakthrough. Because if the machine works, but the human veins keep failing, you have to manipulate the human anatomy to handle the stress.
Right. You have to change the body.
Yeah. And this is where Dr. Emil Holman's work becomes so critical.
Yeah.
And the fascinating thing is, he wasn't even studying dialysis initially, right?
No, not at all. He was studying patients who were actually dying from high-output cardiac failure. And this was caused by massive, naturally occurring arteriovenous fistulas.
Right. So these are abnormal connections where an artery just dumps its high-pressure blood directly into a vein.
Exactly. Holman was observing this catastrophic natural phenomenon and basically reverse engineering it. He began creating artificial fistulas of various sizes in the iliac and femoral systems of dogs.
Wow.
Yeah. And he methodically measured the pressures and blood flows, deducing the profound local hemodynamic rules that govern what happens when you short-circuit that high-pressure arterial system directly into the low-pressure venous system.
Which is a huge fluid dynamic shift.
Massive. And his work established the physiological foundation for the modern arteriovenous, or AV, fistula that we use in dialysis today.
Okay, let's break down that anatomy for the clinical learner listening, because I feel like the terminology can get a bit confusing here.
For sure.
Structurally speaking, what is the actual mechanical difference between an AV fistula and an AV shunt? or bridge graft?
Okay, so in clinical terms, an AV fistula is a direct autogenous connection, meaning a surgeon takes a native vein, mobilizes it, and surgically sews it directly to a native artery.
So you're just merging the patient's own tissues.
Exactly, nothing artificial. But an AV shunt, which is often called a bridge fistula or graft, that utilizes an artificial conduit. The surgeon uses a synthetic tube, typically made of polytetrafluoroethylene or PTFE, to basically bridge the artery and the vein.
Okay, so one is natural tissue, one is a synthetic tube. So why does that structural difference dictate the entire success or failure of the access over time?
Well, it comes down to fluid dynamics and biological adaptation. Consider a side-to-side AV fistula. The textbook details how this creates 4 distinct limbs of blood flow.
4 limbs. Yeah.
Right. You have the proximal artery bringing high-pressure blood in from the heart, and then the distal artery continuing down the arm.
Got it.
Then you have the proximal vein taking blood back toward the heart, and the distal vein. Now, when the surgeon opens that connection, the pressure gradients shift radically because blood, it always follows the path of least resistance.
And it's just physics.
Exactly. The low-pressure vein essentially vacuums the blood. Often, the flow in the distal artery will completely reverse, flowing backward to enter the low-pressure venous circuit.
Wait, it flows backwards, so the vein is suddenly getting blasted with arterial pressure from both directions, essentially.
Exactly. And that blast is crucial. It triggers a process called maturation. The native vein physically dilates, its walls thicken significantly over several weeks to handle the new pressure and that turbulent shear stress.
Oh, wow. So it actually changes structurally.
It transforms into a high-flow, thick-walled vessel that can actually tolerate the large-bore needles required for dialysis. But a synthetic PTFE bridge graft, it cannot do this.
Because it's plastic.
Right. It is a dead, fixed pipe. It does not adapt, it does not dilate, and it definitely cannot heal itself when punctured by a needle.
Which naturally leads us to the biological response, right?
Yeah.
Because we understand the plumbing now, but the moment you alter human hemodynamics or, introduce a synthetic tube into the bloodstream, the body treats it as a massive threat.
No, an absolute invasion.
Yeah. The textbook details how these access devices elicit really aggressive host responses, leading to phlebitis, thrombosis, and infection. And the absolute biggest threat to a synthetic graft is something called intimal hyperplasia.
Yeah, that's the big one.
It's the primary cause of graft failure, specifically at the distal anastomosis where the synthetic tube sews into the native vein. Can you walk us through that?
Sure. To really understand intimal hyperplasia, you have to view it as a well-intentioned healing mechanism that is completely out of control.
Okay.
The trauma of the surgical connection, right?
Yeah.
Plus, the turbulent shear stress of arterial blood slamming against the thin venous wall, plus the continuous presence of a foreign polymer.
Oh, right.
All of that signals to the body that there is an ongoing massive vascular injury.
The alarms are just ringing constantly.
Exactly. So the immune system and the coagulation cascade just go into overdrive. Thrombosis occurs almost immediately, followed by the rapid migration of smooth muscle cells from the middle layer of the vessel wall into the innermost layer, the intima.
Okay, so it's kind of like a biological repair crew trying to fix a tiny crack in a pipe, but they pour so much concrete into the pipe to patch it that they end up blocking the water flow entirely.
That is a perfect analogy. And to make it worse, that concrete isn't just passive material. It is a living, proliferating neointima. It's this thick layer of densely packed cells and massive amounts of extracellular matrix.
That just chokes the vein.
Exactly. And the textbook heavily cites animal models used to understand this cascade. For example, researchers use the rat carotid balloon injury model.
How does that work?
They insert a tiny uninflated balloon into a rat's carotid artery, inflate it, and then literally drag it along the vessel wall to physically scrape away the protective endothelial cells.
Ouch. But I guess that isolates the mechanical trauma.
Right. It isolates the sheer mechanical trauma and the cellular proliferation response. So it allows researchers to study how those smooth muscle cells overreact without the complication of having synthetic materials in there.
That makes sense.
They also use PTFE grafts in baboons because primate coagulation and platelet responses very closely mimic our human reactions to foreign polymers.
Right. And when we talk about coagulation, we really have to look at the specific patient population here. Because patients with end-stage renal disease, or ESRD, they aren't just dealing with structural vessel issues. Their actual blood chemistry is fundamentally altered by uremia.
It is.
They frequently suffer from thrombophilia, meaning their blood is incredibly hypercoagulable.
Yeah, the uremic environment creates this really dangerous paradox.
Hmm.
While uremia impairs platelet function and can actually cause bleeding.
Right, which you'd think means they wouldn't clot.
Exactly, but systemic inflammation and altered protein levels often make ESRD patients highly prone to aggressive clotting anyway. So this underlying thrombophilia just drastically exacerbates intimal hyperplasia.
A perfect storm.
It really is. And the text highlights a severe manifestation of this systemic imbalance. It's a condition called calciphylaxis.
Which is terrifying just to read about.
Yeah.
It essentially turns the middle layers of the small blood vessels into bone.
Basically, yes. It's systemic medial calcification. Calcium and phosphate aggressively deposit into the tunica media, which is the middle layer of the arterioles.
Wow.
So the vessels become completely rigid, the lumens narrow, and that just starves the surrounding tissue of oxygen.
Because the blood can't get through.
Right. This leads to horrific, incredibly painful ischemic skin lesions and subcutaneous necrosis, which often requires amputation. It carries a devastating mortality rate due to secondary sepsis. And the text notes that deficiencies in natural anticoagulants, like protein C, can actually induce this hypercoagulable, calcifying state.
So managing vascular access in a patient whose vessels are actively calcifying and whose blood is trying to clot, I mean, that is an immense surgical challenge.
It tests every skill a surgeon has.
And that margin for error really brings us to the frontline complications. Because clinicians are radically altering blood flow, they have to constantly monitor for severe, localized side effects, right?
Right.
Two of the most critical complications covered in the text are dialysis access-associated ischemic steal syndrome and vascular access neuropathic syndrome, specifically ischemic monomelic neuropathy, or IMN.
Yeah, and distinguishing between these two is a vital clinical skill for anyone in the field. Let's look at steal syndrome first. It is fundamentally a macroperfusion issue.
Okay, macroperfusion.
Right. The new AV fistula or graft is essentially too efficient. The low-resistance venous circuit steals so much arterial blood that the downstream extremity, usually the hand, is left totally starved of oxygen.
So how does that present?
The patient presents with a hand that is visibly pale, cold to the touch, and the distal pulses at the wrist will be severely diminished or entirely absent.
Okay, wait, I'm a little confused here. I understand how steal syndrome deprives the hand of blood. It's cold, no pulse. But IMN is described as a devastating nerve death issue.
Yes.
If we are performing vascular surgery, just manipulating arteries and veins, why does creating a fistula suddenly cause isolated nerve death in the arm? I mean, we aren't cutting the major nerves.
That is the exact physiological puzzle the surgeon has to solve. The key here lies in the vasa nervorum.
Vasa nervorum.
Yeah.
The blood vessels for the nerves.
Exactly. These are the microscopic blood vessels that directly feed the major nerves of the arm. When a surgeon creates an upper arm fistula, a brachial-based access, it causes an abrupt, massive drop in pressure in those specific microvessels.
Oh, I see.
And nerve tissue is incredibly sensitive to ischemia. It dies much faster than skin or muscle. So in IMN, the blood flow to the larger macrovessels might actually remain sufficient to keep the hand warm, but the microcirculation to the nerve is completely cut off.
So that perfectly explains the clinical presentation. A patient with IMN might have a completely warm hand and perfectly intact radial pulses, but their hand is paralyzed because the nerves have literally suffocated.
Exactly. The patient will present with acute, severe burning pain and profound motor weakness, often a claw hand deformity, almost immediately after surgery.
That's horrifying.
It is. And the National Kidney Foundation's KDOQI guidelines flag older diabetic females with upper arm fistulas as the highest risk demographic for this, likely due to pre-existing diabetic microvascular disease.
And because the underlying mechanisms are so radically different between steal and IMN, I assume the treatments are entirely different too.
They have to be. With steal syndrome, because the nerves aren't acutely dying, you actually have time. You can often salvage the fistula using a flow restriction procedure.
Like tying it off a bit.
Kind of. The text highlights the DeVille procedure distal revascularization and interval ligation.
Okay.
The surgeon ties off the artery just past the fistula so blood cannot flow backward, and then creates a bypass graft to route blood around the tie and forcefully push it down into the hand.
Okay, so you say the access in the hand.
Right. But with IMN, because it is acute nerve death, the treatment is immediate surgical closure and ligation of the access.
You just have to shut it down.
Yeah, you must permanently sacrifice the fistula to restore normal pressure to the vasa nervorum and save the arm's function. There's no bypass that fixes it.
Wow. The margin for error in an adult arm is already razor thin. But when you apply those same hemodynamic rules to a neonate in a state of shock, the entire paradigm just shifts. The challenges of pediatric access detailed in the text are honestly staggering.
Yeah, a critically ill premature infant in hypovolemic shock presents one of the most stressful environments in all of medicine.
I can't even imagine.
The target vessels are measured in millimeters. Furthermore, physiological shock causes intense peripheral vasoconstriction. The body shunts blood to the core to survive, which causes those tiny peripheral veins in the arms and legs to completely collapse.
Right, so you can't get an IV in.
Standard angiocatheters are too large, and traditional anatomical landmarks become nearly useless.
But the textbook details an incredible temporary piece of anatomy that provides a life-saving portal for resuscitation, and it's the umbilical cord.
Yes, it serves as nature's pre-installed central line.
That's such a cool way to think about it.
It really is. When a physician surgically transects the umbilical stump, typically about 2 centimeters from the abdominal wall, they find a very specific anatomical arrangement.
Which is what?
There are 2 thick-walled, tightly constricted arteries and 1 larger, thin-walled, gaping vein.
And that single umbilical vein is the golden ticket, right? Because of where it routes.
Exactly. It bypasses the peripheral circulation and the hepatic portal system almost entirely. It flows via the ductus venosus directly into the inferior vena cava.
Wow, straight to the center.
Straight there. This allows the medical team to push massive volumes of life-saving fluids, blood products, and emergency medications directly into the right atrium of the heart.
That is amazing.
It is a vital window of access that circumvents those collapsed peripheral veins entirely.
You know, it is incredible to think about the micro-level precision required to cannulate a 2-centimeter umbilical stump to save a single newborn, while simultaneously, this same textbook grapples with the macroeconomic reality of chronic kidney disease on a national scale.
Yeah, the scope is huge, and the socioeconomic data presented is pretty sobering.
It really is.
The text cites George Eichen's work, Epidemic of Care, to frame the economics of healthcare. Generally, the least expensive 70% of a population uses only about 10% of total healthcare expenditures.
Okay, that makes sense for healthy people.
Right. However, the most expensive 1% of the population consumes an astonishing 30% of all healthcare resources.
And ESRD patients heavily populate that top 1%, right?
They do. Hemodialysis is an incredibly resource-intensive, life-sustaining therapy. A single vascular access failure isn't just a clinical setback, it is a massive economic cascade.
Because it's never just one cheap fix.
Exactly. When intimal hyperplasia clots a graft or a central line causes sepsis, it triggers emergency room visits, complex salvage surgeries, prolonged ICU stays, and really costly antibiotic regimens. This exponentially inflates systemic healthcare costs.
Which perfectly explains why the guidelines so heavily emphasize early referral to a nephrologist. The goal is to establish a mature, autogenous AV fistula months before the patient actually needs dialysis.
It's exactly.
You want to avoid the desperate high-cost placement of emergency central venous catheters at literally all costs.
Proactive access planning is where clinical outcomes and healthcare economics intersect perfectly. A functional, mature native fistula has the lowest infection rate, the lowest thrombosis rate, and costs the system a fraction of what managing a failing synthetic graft does.
Well, it's just better for everyone.
Ah.
So, to prevent those cascading failures, clinicians rely on precise diagnostics, and they learn from historical unforced errors. Let's cover some clinical pearls from the text, starting with imaging. Ultrasound versus venography.
Okay, yeah. Both modalities are critical, but they operate on totally different physical principles and serve different diagnostic purposes.
Right. Let's start with ultrasound.
So ultrasound uses high-frequency sound waves. It is non-invasive and excellent for mapping superficial anatomy. It provides precise measurements of vessel diameter, the exact depth from the skin, and it can assess the velocity and health of the arterial inflow.
But it has limits, right?
It does. Ultrasound waves cannot penetrate bone or deep pockets of air. Ah, okay.
Venography, on the other hand, involves injecting radiopaque contrast dye directly into the vein and using fluoroscopy, which is real-time X-rays, to watch the flow.
So it's more invasive.
It is, but it is the gold standard for identifying focal stenosis, particularly those deep central venous blockages behind the collarbone or ribs that ultrasound simply cannot visualize.
Because of the bone. That makes perfect sense. Knowing the limitations of your tools is essential, but equally essential is understanding the limitations of the surgical environment itself.
Absolutely.
The textbook features this highly practical section by Dr. Eric Leidenheim titled 10 Mistakes to Avoid in Dialysis Access Surgery. And I found this fascinating. Mistake number 1 on that list is operating on an HIV or hepatitis C positive patient under local anesthesia.
Yeah, that surprises a lot of students.
I mean, is that protocol purely to protect the surgical team from needle sticks? Because I assume the patient would be numb anyway.
The primary goal is absolutely the safety of the operating room staff, and it underscores the gritty reality of vascular surgery.
When you're operating on a patient with a known blood-borne pathogen, the surgical field must be immaculately controlled. If a patient is under local anesthesia and they suddenly feel a sharp pain or even just experience panic, they will flinch.
Oh, yeah.
And a sudden, unexpected movement while the surgeon is holding a sharp scalpel or maneuvering a suture needle deep within a bloody field. That places the entire surgical team at extreme risk of a life-altering transmission.
That is terrifying, honestly.
It's a huge risk. Utilizing general anesthesia or deep regional nerve blocks ensures the patient remains perfectly immobile. This protects the provider and allows for a much safer, more precise operation.
It's a stark reminder that this textbook really blends deep biological theory with hard-won, real-world operational wisdom. Leidenheim points out other critical mistakes too, right? Like failing to meticulously document all possible complications during informed consent.
Always document everything.
Right. Or placing a fistula in a borderline vessel when your clinical judgment and ultrasound data tell you it will likely fail.
Which happens more than you'd think. Surgeons naturally possess a bias toward action.
You want to fix it.
The instinct is to try and fix the problem. But attempting to build an access in a tiny, heavily calcified vein, just because you hope it might dilate, it subjects the patient to unnecessary trauma, it destroys whatever usable collateral veins they might have had in that arm, and ultimately delays effective dialysis.
It does more harm than good.
Exactly. Often, the most difficult surgical decision is demonstrating the restraint to just step back and not operate on a specific site.
Well, we have covered immense ground today. We started with Dr. Kulf's rudimentary cellophane and beer can dialysis machine. We explored the mathematical fluid dynamics of Emil Holman's dog models and detailed the complex cellular cascade of intimal hyperplasia using those rat carotid balloon injuries.
We really span the whole field.
We did. We've navigated the physiological paradoxes of uremic calciphylaxis, the high-stakes anatomical reality of the pediatric umbilical stump, and the critical diagnostic boundaries between ultrasound and venography.
And the common thread here is that vascular access is a highly dynamic discipline. It requires a mastery of mechanical fluid dynamics, a deep understanding of immunology and coagulation, and the technical restraint to execute precise surgical interventions.
Right.
So to reinforce today's deep dive, I have a clinical review exercise designed specifically to test the applied knowledge of you, the medical learner listening right now.
Oh, perfect. Let's hear it.
Okay. A 65-year-old diabetic female patient presents with acute, severe burning pain and profound motor weakness in her hand immediately following the surgical creation of a brachial-based arteriovenous fistula. Upon examination, her hand is warm to the touch, and her distal radio and ulnar pulses are intact and bounding.
Okay, warm hand bounding pulses.
Right. What is the most likely diagnosis, and what is the definitive immediate treatment?
All right, let's solve this.
Based on the presentation of an acute neurological deficit, so the severe pain and motor weakness occurring despite adequate distal arterial macroperfusion, which we know because of the warm hand and intact pulses, the diagnosis is ischemic monomelic neuropathy, or IMN.
Which is that microvessel drop in the vasa nerve we talked about.
Exactly. Because this represents the acute ischemic death of the nerves, the definitive and immediate treatment is surgical closure and permanent ligation of the new axis to restore normal microcirculation.
So you permanently sacrifice the fistula to save the function of the arm. It is a brutal trade-off, but clinically the only correct one.
Exactly.
Well, as we wrap up this deep dive, I want to leave you with a final thought to ponder. We spent a lot of time analyzing how the human body aggressively rejects synthetic materials, mobilizing smooth muscle cells to create that thick, concrete-like intimal hyperplasia that chokes off the graft.
Right, the uncontrolled healing.
Exactly. But as bioengineering and biomaterials continue to advance, could we engineer a synthetic vascular graft that doesn't just sit passively in the vein, but actively releases highly localized immunosuppressants, or perhaps gene therapies, directly at the anastomosis site.
Oh, that's an interesting concept.
Right. Could we effectively paralyze the body's local healing cascade, tricking the vascular system into accepting a permanent artificial conduit without ever triggering that cellular repair crew?
That would change everything about how we handle synthetic grafts.
It's a fascinating frontier for the next generation of medical innovators to explore. Thanks for joining us on this deep dive.